This is Dr. Andrew Yen over at St. John's, and we're going to talk specifically about complex total knee replacement. So some types of arthritic deformities are straightforward, but some types of knees have severe structural defects with soft tissue imbalance and soft tissue deformity. So we'll take you through the process we use to characterize, model, and then correct defect and correct deformity. So the best way to go through this is with a case study. So we can see in this patient, here's femur, here's tibia. We can see an extensive amount of arthritis. So clearly this patient is bone on bone. All the cartilage is gone. But at the same time, there's a lot more structural change happening. So if we look at the tibia, here's the tibia. This is the lateral plateau, and we should see on the opposite side a medial plateau. But instead we see this enormous structural defect with the medial plateau broken off to the side. As a result, the femoral condyle, which should typically be supported on this plateau, has now collapsed into the defect. And as a result, the knee has become bow-legged and the tibia has shifted off to the side. So a lot of mechanical change going on through the knee. And I'm going to show you how we modeled this two-dimensional appearance into 3D, how we characterize the area of the defect as well as the volume of the defect. The planning begins prior to surgery. So this patient will get a CT scan so we can make an anatomic model of the knee as well as of the leg. And so we can get a clear idea of the extent and the area of the deformity. When we look at the femur from the front, from the axial view, and from the side, we can see there's arthritic change, but there's not a lot of deformity. The femur has maintained its shape. In this knee, all the deformity is happening on the tibial side, especially in the medial side. When we look axially, we can see healthy bone everywhere, but this entire area of bone is missing. So we can see area, but we can also see volume. We can look at this concavity here, and we can see a substantial amount of bone. A little over 6 to 7 millimeters is missing in this area. And so from this view, we know the appropriate size, medial, lateral, anterior, posterior. We know the appropriate rotation, we know sizing and positioning, and we also know the size of the defect. We'll then look and see how our plan correlates with the soft tissue imbalance that the patient actually has. We'll look at the knee under anesthesia to determine the extent of the deformity in both extension and in flexion. So I'll show you extension first. So this patient has a Varus deformity, so the knee is bow-legged, and we can see that it's come off to the side. But most importantly, we can see that there's an asymmetry. There's 16 millimeters of opening on the lateral side. Here's the fibula, this is lateral, and only 5 millimeters of opening on the medial side. So this is that extensive collapse that we saw. So we see Varus, and we also see a 17-degree flexion contraction. So this knee is bent, it's unable to straighten out. Let's take it the flexion view. We see a similar type of asymmetry in the flexion view, specifically a Varus deformity with asymmetry. So on the lateral side we see 11 millimeters, and this is pretty tight, but we also see a very tight medial gap in flexion. So flexion contracture and deformity with collapse on the medial side. Okay, now that we've established the appropriate size and placement from our bone model and characterize the deformity in two planes, we're now ready to make micro adjustments in terms of millimeters and degrees to offset the deformity and recreate symmetry both in extension and flexion. So we'll first work in extension. We'll put 3 degrees of Varus on the femur, 3 degrees of Varus on the tibia, and that will do two things. It will decompress the asymmetry. Remember, we were wide open here and we were closed down here, so we'll decompress the tight gap in extension. But very importantly, it will also, by putting Varus on it, will reduce the amount of structural defect on the medial side. So we dropped it by 1 millimeter and we put 3 degrees of Varus, and then this defect went from 6.5 to 3. And we want to keep it below 5 because above 5 degrees is when we will need a structural augment. When we look at the tibia from the axial view, we can look at the area, and from the side we can look at the volume. And from the area we can see that even though we have this defect, over 80% of our plate will be supported on host bone. And then when we look at the volume, we can see actually the volume is quite small. It's less than 3 millimeters within this area. And the majority of our knee will be covered and maintained with actually anatomic organic support. I think one of the most powerful things that we can do is that we can virtually image what our anticipated defect looks like so that there are no surprises. And so here is what we had planned on the tibial surface, and we're specifically looking at the area of the defect, or compared to the cut surface. And this green represents host bone, this hemisphere, or this crescent, represents our defect. And we can see here we pretty much obtained what we had planned at the time of surgery. Healthy host bone, and then a small area for defect in terms of area. Let's look at it from the side. From the side, we're actually looking at the volume of the defect, and we can see we've got nice coverage all the way around. In this small little area in the posterolateral corner, we have only a 3 mm defect. And this area, or this volume, is quite small compared to the volume of bone that would need to be removed to put in a 5 mm augment. It'd be 5 mm down, and this entire hemisphere would have to be removed. And in this knee, having organic structural support is going to be much healthier than synthetic support with removal of this entire hemisphere. And then one of the best things that we can do is that we can then test our assumptions and the changes that we made. Again, we are looking for symmetry in extension and inflection. Specifically the symmetry, 18 mm between the medial and lateral side. So before there was a wide gap, narrow gap here, and we've restored symmetry here. Knee is lined up, and we'll also do that in flexion. And we can also see that we've reproduced our flexion gap, and it's balanced, and we have 18 mm on the lateral side, 18 mm on the inside. So with the trials in place, we know that we have good structural support on the tibia. We managed this defect with good stability using host bone by putting 3 degrees of Varus and lowering it. But also, just as importantly, we've corrected the structural defect. We've taken the knee out of Varus, and we've reestablished 18 mm on both sides in flexion and extension. And then in the final check, we'll get a post-operative x-ray. So if you remember our knee previous, and I'll show you another image of that, we want to make sure that the femur and tibia are aligned, that we have an even spacing between femur and tibia. And in this knee, we've used a universal base plate, so there's a little bit more support to increase the volume of fixation along this tibial surface. And we've filled in this 3 mm gap with cement to restore structure where it had collapsed. And this is lateral. You can see we've got appropriate sizing, anterior, posterior, and good cementation and balance. And then let's take a look and see where we were. So this is where we were prior to surgery. Femur, tibia, completely bone on bone, medial tibial collapse, and then subluxation. You can see now we've restored a separation so there can be transfer of load between the bones without the bones grinding. We've restored the medial tibia support where it was absent before, and we've corrected alignment. So now femur and tibia are lined up, and the tibia is no longer subluxed. Okay, so that's a brief overview with the very complex knees. Routine knees are much more straightforward, but it shows the power of preoperative planning and the anticipation of structural and soft tissue defects, and the importance of soft tissue adjustments or small adjustments in angle and in depth to ensure that we're able to reproduce symmetry and restore alignment. Thank you very much.